So first of all, thank you for coming. This is a good attendance for us. We had 89 register, 89 practitioners, and you can see that you're dispersed pretty well throughout the Alabama and Mississippi region. When we began way back when, back in 2005, we thought that the bulk might be concentrated in Birmingham, but you can see that that's not the case. It's pretty well spread out over the state. We began initially as a general dentistry practice-based research network, and we've gradually expanded to include specialists as studies have come up that we think specialists might be interested in. So we have 5 specialists attending this year's meeting. They are periodontist, endodontist, pediatric dentist, I think this oral surgeon, okay? But the bulk of us are general dentists. We also have 2 NIDCR program officials. They've chosen to sit on the front row, and I'll introduce them later. We're very glad to have them with us. I hope you all know by now that National Institute of Dental Craniofacial Research is one of the institutes at the National Institutes of Health, and they are our main funder. They stuck their neck out in 2005 with what at the time was considered a kind of a risky initiative that might not work out. Well, you've proven that it can work out, and it's worked out exceedingly well. And I will discuss a little bit of detail about that as we go through tonight's talk, because you deserve an immense amount of congratulations. We also have 20 UAB faculty and staff. Some of those faculty are actually practitioner investigators. If they practice in the faculty practice or see patients directly in one of the school clinics, then they are eligible, and some of them have joined the network, and it's worked out well because they oftentimes are initial testing sites because they're awfully close, some of them in the same building. The coordinating center for the network is based here at UAB, and so we're glad to have them in attendance as well. The next cycle, the next 7-year cycle that we hope to get funded, we propose to include a number of regions, one of which is based at the University of Rochester, so we're glad to have 2 of them attending as well. They're interested in seeing how an annual meeting works, so we welcome them. So I mentioned the 2005 to 2012 era. That's the first 7 years of funding, and we began back in 2005 as a network that includes 4 U.S. regions and 1 Scandinavian region, as you well know. So we are the Alabama-Mississippi region. And when we first attended meetings of researchers and practice-based research networks back in 2004 and 2005, we learned a lot. But due to the funding and commitment from the Institute, the NIDCR, I would say that we as a field, pretty quickly leapfrogged ahead of them. You may remember that they funded 3 networks back in 2005, and we were one of those. Ours has been, I think, especially successful. And I would say it's because we've been committed from the outset, being a network with, about, and for practitioners and their patients. That has been a key to our success. I think we've adopted kind of a customer service type approach, realizing this needed to be a win-win for everybody involved. So it's about practitioners and their patients, because we are interested in seeing how you engage the network. Do you change practice at all? What ideas for studies do you recommend? That sort of thing. It is definitely with practitioners and their patients, because we've made a point of engaging you at every step of the process, and you've done exceptionally well. It's for practitioner investigators and their patients because we want you to derive a substantial amount of benefit from this. It's crucial for long-term success that it be a win-win. So you're the half of that equation. You need to be getting a lot out of this, and I'll discuss a little bit about that later. We've also made a point of being very practically oriented. It is so important that the studies that we do, when they're completed, that they actually make a difference in your practice, that you care about them. that the results you feel like can apply to your practice. We used to have a mantra that so much of clinical research before the PBRN era was scientifically rigorous, statistically significant, but clinically useless. Some of it referred to as clinically irrelevant clinical research. So that PBRN moved that forward, and it's worked so well because we've engaged you directly in coming up with ideas for studies, testing out studies, so that you can provide input at every step of the process. So the bottom line, it's been very practical science. It's not ivory tower ideas that academic types would dream up. One of the first steps in the process is not only idea generation, but is field testing. Does this study is it gonna flow and not unduly interrupt your busy clinical practice? Do you like the data collection forums? Is this topic working out? Where would you be collecting this information? Would you prefer to do some of it in the waiting room, reception desk, all done back in the operatory? So here one example from our prevalence of questionable occlusal caries study. We're thankful to Dr. Sanderson, who's in the back row, and Dr. McGee as well. I don't think he's here, for field testing this study. And Alabama has been an especially important region for field testing because a lot of studies have been field tested here in Alabama first. We also did a fair amount of feasibility testing on the blood glucose study, thanks to Dr. Jackson, who is here tonight. Dr. Palmore is here as well. I saw him earlier. Where is Dr. Palmore? There he is. Okay. He will also be leading a breakout session tomorrow. So this study was kind of potentially pushing the envelope for our dental profession. So the dental profession would be testing blood glucose. So we weren't sure if this is something that would be feasible, that dentists and patients would actually like it, would find it, a favorable thing to do. And there are 2 papers from this study, and one of them happens to be in the current month's issue of the Journal of the ADA. We have another one currently under review. So I can tell you that engaging practitioners at this step and all the others has just been crucial, and it's changed how we've done studies, what we've asked, what data we've collected, and how we've made it practical for each practice. These are some photos from previous annual meetings. People had concerns back in 2005 that would practitioners be good at presenting the findings? Would they be comfortable and effective at local, state, national, and international meetings? Would they be effective at practitioner audiences? Would they be effective at presenting to researchers? The answer has been a resounding yes. They've also presented, these are photos from International Association of Dental Research and American Association for Dental Research meetings. In the top right is Dr. Gary Anderson. He's also here this evening. He's one of the executive committee members that represents your region. They've also done exceptionally well at presenting an oral as well as poster sessions. On the right side is Dr. Wallace. She's also here tonight. Thank her for all her great involvement. We've considered her one of Dental PBRN's best friends since way back when in 2005. She comes through all the time. To the left is Dr. Paul Benjamin. He is actually presenting at the ADA Evidence-Based Dentistry Conference, which is, I believe, today and tomorrow, actually. We had invited a couple ADA representatives, and they intended to come until they realized that's the weekend for the Evidence-Based Dentistry Conference. We've also been successful because we've done a lot of studies. We've done 22. That's a lot in a 7-year period. These studies have been large, some have been medium, others small. They've been on a wide range of topics. You see some of them listed here. They've been on about every study design imaginable. If you go to an epidemiology textbook, you'll see a list of various study designs. We've done almost all of those. We've done cross-sectional, we've done case control studies, prospective cohort studies, retrospective cohort studies, randomized clinical trials. That leaves just 1 or 2 left we haven't done. So there was a lot of skepticism. Could you actually do these well? You've done them in an outstanding manner, so congratulations. You see the wide range of topics. They have to do with run-of-the-mill general dentistry topics such as restorative dentistry, but they've also investigated osteonecrosis of the jaw, TMJD, pain and root canal therapy. Here's the remainder of these 22. So they've really run the gamut. So I can tell you that you've impressed a lot of people that you can not only do studies well, but you can do a wide range of study designs, large studies, small studies, wide range of topics. So you should feel very proud of that. I mentioned that we believe that one of the keys to our success is that we've emphasized staying constantly in the win-win zone. So we continue to touch base with you about what you see as the benefits in participating in the PBRN. And so these are ones that come from you. We often hear that one of the benefits is distinguishing your practice from other practices, so it can actually act as a practice promoter or a practice builder. We regularly hear that it increases the practice's visibility and stature among dental patients, that it enhances communications with patients by showing that the practitioner-investigator cares about the scientific basis of clinical practice. So patients pick up that you're thinking as you're doing, okay? You're considering what the scientific basis of this is, and so you're asking yourselves throughout the day, is this the best way to do this currently? It also expands the vision for patient care by including a formalized research and quality improvement component. You do receive financial remuneration. You don't get rich doing it, but it does convey that we respect your time. We're very grateful for that. It allows you to see what's effective in your practice compared to other practices. So every study that we've done, we've made a point of giving practitioner-specific results to you, and allows you to look at the results in your practice to compare it to other practices in your region, as well as throughout the network. And we get, we're told that you really like seeing those practices. Another tidbit, we send out monthly e-updates. I hope you're getting those. The past one gave some additional study results. And because we subscribe to constant contact on this service, this email service, we can tell what percentage of people are actually clicking on the links. And so we can tell that getting study results that way is popular as well. So the number of clicks is higher that month, okay? Practitioner investigators decide what studies are done, what treatment is done, not third parties. So way back when, there was some concern that PBRNs and maybe this evidence-based dentistry initiative overall might be some concealed way for insurance companies to determine what we do. So that doesn't happen in PBRN research. You decide what studies are done and what treatment is done. We're also told that a benefit is presenting at local, state, national, and international meetings. You've done a lot of that. You've done really well on that. Another benefit, you tell us, is that it provides a venue for collegial interaction and exchange of ideas with fellow practitioners. You like the CE credits, you'll get that on the way out the door. Certificates suitable for framing are also considered a positive. So I've mentioned that we think of it as staying constantly in the win-win zone. Others would say that they would characterize it as research that works. On the upper left, Dr. Patrick Foy, he spoke at this meeting 2 years ago. He is the practitioner-investigator representative for the Minnesota region. He began with skepticism. He also wondered, is this some ploy for insurance companies to determine what we do? And so he spoke about that at this meeting a couple years ago. He's a former president of the Minnesota Dental Association. And so he ultimately became a very active practitioner, and he ultimately concluded that this is a good thing, that this is research that works, as he characterizes it. So we've accomplished a tremendous amount in the past 7 years, and I can tell you that a special congratulations goes to the Alabama-Mississippi region. It's the region with the largest number of practitioners. It's the region that has been involved in pilot testing most of the studies, and has actually been the lead region in pilot testing and feasibility testing for most of the studies. It's enrolled a tremendous number of patients. So for example, in the Reasons for First Restoration study, This region enrolled more than 1,500 patients and 2,800 restorations. That's a huge study. Similar for the reasons for replacement or repair was also a very large number. There's also special congratulations to particular practitioners in this highly productive region. So we've got, I think, 3 slides of really high achievers. And one of those, Dr. Allen, would you please stand up? Come on, there you go. Dr. George Allen, thank you. He's from Mobile, and we can characterize him as the most active practitioner, okay? We say that because he's been involved in 15 clinical studies, surveys, and or meetings. Okay? Our interaction with him, I remember he and I tag team, I guess it was in 2005, may have been late 2004. Maybe it was a Mobile District Dental Society member, which is actually in Daphne across the bay. And so he and I have interacted a lot in the past 7, 8 years, and he's done an excellent job. So congratulations, Dr. Allen. Dr. Keith Calvert, is he here tonight? I haven't seen him. Dr. Calvert? No? Okay. He's from Birmingham. He has the distinction of having enrolled the most restorations in study 4. Remember, that was the reasons for first restoration. We were looking for about 50 restorations from each practitioner. And this is one of the lessons learned early on. It became clear that some would definitely reach 50. Some would reach 50 if we gave them quite a few more months. Some would not. Well, we learned that at that point that it's a matter of enrolling both practices and number of restorations per se. So we asked that he consider to keep enrolling, and you can see that it was very productive. You're not seeing double. It's just because Dr. Shaw is just incredibly high achiever, and she's here tonight. I saw her. Dr. Shaw, where is she? Dr. Shaw, please stand up. Okay, thank you. Her practice is in Fairhope. And so study 5 was the repair or replace restoration study, and we were looking to enroll 50. She overshot by quite a bit. Thank you very much. And this is also one of the lessons learned. This was at the time when the economic downturn was particularly down. It was clear that enrollment of restorations and practices was not going to be at the rate that we had hoped for. So we turned to Dr. Shaw to go above the 50 that we were looking for any given practice. You can see that she exceeded that a tremendous amount. Similarly, in the questionable occlusal caries study, we were looking, I believe it was 50 lesions or 25? Can't remember. 25, yeah. So you can see Dr. Shaw has a very busy practice, so thank you very much for your commitment. Doctors Keith and DeCiara, I don't think are here. Dr. Keith, I believe he sent us an email yesterday that he's got a family medical emergency. And Dr. DeCiara is moving his house this weekend. Not his practice, but his house. Yeah, okay. There's no perfect weekend, okay? The patient satisfaction study, many of you participate in that, but this is one that was linked to the repair, replace, restoration study. And so patients were coming in to have a restoration repaired or replaced, and we wanted them to complete a patient satisfaction survey. We also asked that the dentist do that. There's a talk tomorrow about that study to refresh your memory. We were very anxious about that study because we wanted patients to complete a satisfaction survey after they had left the office. And that had to be that way because we needed the anesthetic to have worn off. So that meant we were asking them to complete a survey that evening or the next day. And so we were hoping for 70% return. And we ended up with 80%. So we were really pleasantly surprised. And you can see Dr. Keith led the way with 94%. So he's got some really, I don't know if they're really satisfied patients or compliant or whatever, but it worked out really well. We also did a study on perioperative and persistent pain associated with root canal therapy. And Dr. Chiara was a top achiever there on that one. So congratulations to him. So we're still talking about the current 7-year period. So I mentioned that the Dental Institute funded in 2005 3 networks, not just ours. They funded the Northwest Precedent Network based at the University of Washington and Oregon Health Sciences University, and the Pearl Network based at New York University. And as a 3-network entity is called Condor, and that stands for Collaboration on Network Dental and Oral Health Research. And so we collaborated on infrastructure issues, some research projects, data standardization. It's on the same order as enthusiasm as watching grass grow when it comes to data standardization. But we collaborated on that. That worked out fine. The Northwest Precedent Network, I mentioned, is based in Seattle and Portland. And here's the map. They involve Washington, Oregon, Idaho, Montana, and Utah. Okay, and you can see where their practitioners are located. That worked out well because remember, we have a region, the Permanente Dental Associates region, which is also based in Oregon and Washington. And we had kind of a gentleman's agreement that we wouldn't step on each other's toes, and it worked out fine. The Pearl Network, based at New York University, the bulk of their practitioners in the Northeast region. They also have practitioners in quite a few other states. So in 2005, we had a lot of people approaching us and a lot of skepticism, and they were skeptical, would you really be able to recruit a large number of practitioners and engage the network? Would you be able to establish the necessary regulatory and contractual relationships? Even though you're in busy clinical practices, would you be effective at doing studies? Would you really contribute ideas for research projects? Would you really participate at every step of the way? And the answer has been a resounding yes. So I hope you feel an immense amount of satisfaction that you proved a lot of people wrong in a really big way. So congratulations. Then in last year, the NIDCR came out with a request for applications and proposed a second 7-year funding cycle. So we submitted the application in May, and it was limited to the 3 networks who were funded in 2005. So we submitted an application, and the Pearl and Precedent networks got together on a single application, so they were reviewed. Ours did well, so we're very hopeful that we will be receiving funding. There's no official word. We're hopeful that will be in the coming weeks. But that's the extent of the official aspect of it. So it was a limited competition, and we did well, so we're very happy about that. And I can tell you that a large part of that is because you've been such a productive and participatory group of practitioners. You've proven time and time again that you can accomplish a lot and do studies that will have immediate clinical impact. So that's the 7-year history. What about the next 7-year history, which I hope that we'll be getting funding for and hope that we'll be finding out very soon. So the RFA proposed an additional 7-year period. That is unusual for NIH. Typical grant is 3 to 5 years. And so they've committed to additional 7-year funding potential. So we're very happy about that. And so we're now looking forward, hoping to launch forward into another 7-year period. As we think through a vision for the next 7-year period, I think it would be helpful to keep 2 things in mind. First, we've certainly been about developing practice-based evidence. And I love this quote, if we want more evidence-based practice, we need more practice-based evidence. And so that's half of the coin. And that half of the coin is that we're generating a lot of knowledge, a lot of evidence, a lot of information. But that knowledge needs to be acted upon and actually needs to be taken in and used in your daily clinical practice. So that's really the other half of the coin. So I think in the next 7 years we need to be cognizant of that. I think we've placed a greater emphasis on this one side of the coin, which is generating evidence. And we know that it is practical evidence that you feel is going to have immediate impact in your clinical practice. But so much of evidence sits on the shelf and doesn't get implemented. And in the cardiovascular literature, a couple articles cited here, said that better delivery of established therapies would save more lives than the next innovation of therapy. Okay? So what they're saying is that if all we did was move the evidence that we currently have into practice, we'll actually be accomplishing more than trying to come up with new evidence. Okay? The same thing applies in dentistry. We can generate evidence that will be clinically applicable, but we also need to be cognizant that that evidence actually move into daily clinical practice actually makes a difference. And the PBRN setting is the perfect place to do that. So at one end of the spectrum, we have laboratory research. This is animal research. This is a good research context when the question is not, or the treatment is not ready for humans. The next step up, clinical trials in an academic setting, when the treatment is not ready for patients. And then we have practice-based research, that would be us, when evidence or treatment is not ready for practices. Okay? So we can generate evidence, but if it's not being used in daily clinical practice, what good is it? And then finally, community-based research. We proposed, quote, the National Dental PBRN. We proposed a national network, and this national network would comprise 6 regions. So we would comprise not an Alabama-Mississippi region, but a South Central region. Our colleagues at the University of Florida would lead a South Atlantic region. Colleagues at University of Rochester would lead a Northeast region. Our colleagues at Health Partners Research Foundation would lead a Midwest region. Portland, our Kaiser Permanente group would lead a Western region, and San Antonio would lead a Southwest region. So if we are funded, we have a tremendous opportunity. We have a tremendous opportunity such that at the end of the funding cycle, it would be wonderful if in 2019 the nation looked back and said that the National Dental PBRN were a precious national resource. We can do that. We've already proven in the first 7 years that we can accomplish a tremendous amount. So we are very eager for your ideas at this meeting. And 2 of the topics at the breakout sessions are really focused on this. So wouldn't it be great if the National Dental PBRN in 2019 were viewed as a precious national resource, and the profession sees the network as a thought leader in improving dental care and oral health. They see it as doing studies that have the greatest clinical impact and actually make a difference in how care is provided. That we are seen as the best venue to test methods to move evidence into routine practice. That we are seen as a means for the profession to collaborate on big ideas. That we would be a means to collaborate with the American Dental Association, Academy of General Dentistry, Alabama Dental Association, etc., to identify win-win opportunities. So we have collectively a tremendous amount of expertise and experience that we can engage these organizations in to identify win-win opportunities. And what if by 2019 we were seen as a go-to source for what works, when, and for whom, because of the studies we do and because of what we accomplish collectively. Here's an example of the ADA Evidence-Based Dentistry website. I would say 20 years, maybe as late as 10 years ago, there was skepticism that evidence-based dentistry was looking to control what we do in daily clinical practice. But I see it as a marker that if the ADA embraces it, I mean, they clearly embrace it. They have a web page and now a range of activities devoted to it. And even today, having an evidence-based dentistry conference up in Chicago, that it has clearly become mainstream. And PBRN research is about evidence-based dentistry. It's about generating this evidence, in this overlap in the Venn diagram, the scientific evidence. But it's also tailored to take into account your individual expertise and taking into account individual patients' needs and preferences, the one sitting in your particular chair at that particular time with his or her own particular needs and preferences. If we are looked upon as a precious national resource, then this would be an opportunity for our profession to lead rather than be led. We believe that PBRN patients will see the network as the leading edge, that they'll see your practice, because you're participating in the network, as being at the leading edge, and that you are at the forefront of staying current. We did a pilot focus group in the Alabama region, I don't know, several months ago. And one of the recurring themes from the patients these are PBRN participants, one of the recurring comments from them was that they like the fact that you're in the PBRN because they feel like that means that their dentist is staying current, that you're actually paying attention to the latest evidence, that you're asking throughout the day, is this the best thing to be doing? So they see that as a major benefit to go to a dentist who is staying current. And so being in a PBRN, they see that matching up very well. If we are become a precious national resource, then I believe that one day our profession will be looked upon as one that is committed to research and quality improvement. Wouldn't it be great if one day the cocktail conversation was that, oh, you're a dentist, do you happen to do research and quality improvement? And your response would be, well yeah, I'm a dentist, of course I do that. I mean, that's what we do as a profession. So I see the National Dental PBRN as leading us to that point. Then research and quality improvement is just what we do because we're interested in what is the best treatment for our patient, and so we're trying to stay at the leading edge throughout. So now is the time and place to be creative. We're very eager for your ideas. We're hopeful that these ideas will come in tomorrow's breakout sessions. Dr. Wallace will lead a breakout session about ideas for new studies in the next 7-year cycle. Dr. McKeeja will lead a breakout session about what do we need to do and accomplish and be such that we'll be looked upon as a precious national resource. What are the best ways for us to communicate and interact? How do we create a community of learning and improvement across the nation? So this will be a national network, 48 contiguous states, that's a large geographic area. How do we best communicate and learn? How do we best engage organizations like the ADA, AGD, ALDA to create win-win opportunities? We have an immense amount to bring to the table, and if we collaborate with them, it will lead to win-win opportunities such that we will be better off as a network if we do that. What are the best ways to communicate and measure success and communicate that success? So if we are a precious national resource, why can we say that? What are we doing? How are we going to measure that? How can we best add value to your practice? How can the network best convey its mission and value added to your patients in your practice? So in the current cycle, we've used things like patient pamphlets that introduce the dental PBRN. We're eager for ideas to expand that, providing a link on your own practice's website to our page, for example. Would it be useful for us to provide a wireless device that we could send streaming photos or news that would sit in your practice, reception desk or whatever? So we're eager for those type ideas. And now is the time to provide those ideas at tomorrow's breakout sessions. Here's another example. We've been thinking about logos, for example. So here's another opportunity to provide ideas. You can see we're still at the ground floor. So if we are funded, we need to come up with a new name. And I'm interested in, so let's divide these into these 3 rows. So the top row is this dental research group here. In the second row and third row, I'm interested in your initial reaction. If you had to choose one, which would you choose? So if your favorite is on the top row, raise your hand. Okay, we got 3. If your favorite is on the second row, raise your hand. Okay, that's a lot more. If your favorite is on the third row, raise your hand. Okay, the second row wins. Okay, which of those 2 on the second row? Is it, if it's this one, raise your hand. Okay, so now everyone in the room has to choose between this one or that one. Even if you don't like that row, you got to choose now. Sorry. Okay, so do you like this one? Raise your hand. Okay. Do you like the one on the right? Okay, we've had a lot of internal debate about that, and this has been a favorite of some. This has been the favorite of a lot of people in conference calls and things like that, so thank you. And so 1/3 of you will be at one of these two sessions tomorrow, the one about providing ideas for study ideas for the next cycle, also providing ideas for how can we become a precious national resource. So if you are in one of those 2, please be energetic, please be vocal. If you're not, see Dr. McKeeger or Dr. Wallace, provide your ideas anyway.